and colorectal cancer. She's an invited speaker at international conferences such as Pancreas Summit 2023 and the Asia Pacific Digestive Week. She held leadership roles in medical education, including the deputy head of the third year PPD module and chief coordinator of medical electives at UKM. She's also a member of several professional organizations, including the Malaysian Society of Gastroenterology and Hepatology, the American College of Gastroenterology, and the American Association for the Study of Liver Disease. With that, I would like to invite Dr. Deborah to deliver her lecture.
Thank you so much for that kind introduction, and kudos, Abbott, for a very well-conducted workshop. So my name is Deborah, and I'm a gastroenterologist and hepatologist from National University of Malaysia Medical Center. So these are my disclosures. So what I'm going to be talking to you today is about functional dyspepsia as well as gastroesophageal reflux disease, the pathophysiology of these two diseases, the mechanism by which underlies the generation of symptoms, and also how we can effectively treat the symptoms in order to improve patients' quality of life, and what are the red flag symptoms that we need to refer the patients to tertiary care when they arise. So this is what we'll be going through in the next 30 minutes or so, and this is what we're going to be discussing about. Okay, so now we're going to switch gears and talk about what are disorders of gut-brain interaction. So we know that in the recent year, with the change of the nomenclature from Rome 3 to Rome 4, we've also seen a shift in the terminology of functional gastrointestinal disease to disorders of gut-brain interaction. Now, this is very important because, firstly, we know that the term functional can be stigmatizing, but more importantly, this shift in nomenclature reflected the underlying understanding of the pathophysiology and the mechanism by which symptoms in disorders of gut-brain interaction are generated. And most of the causes of symptoms are due to a combination of factors. More than one can be present, and they can include motility disturbances, and this can be improved by a prokinetic agent, visceral hypersensitivity. Now, it's very important to distinguish which is the underlying cause of the symptom generation, because we know in the setting of visceral hypersensitivity, a neuromodulator with a tricyclic antidepressant is an excellent option for symptom relief in patients. Altered mucosal as well as immune function, duodenal hypereosinophilia, commonly seen in functional dyspepsia, and we know in this setting, diet modification with low FODMAP diet can actually improve symptomatology of dyspepsia, gut dysbiosis, as well as altered pain in the central nervous system processing. So now we're going to talk about the prevalence and how commonly we see disorders of gut-brain interaction. It's very important for us to understand the prevalence because this gives us a reflection and a snapshot of how often we see this in our clinical practice. So worldwide, disorders of gut-brain interaction has a prevalence of 40.3%. This is staggering because every 4 patients that walk into your consult are going to have a disorder of gut-brain interaction. Now, bringing it closer to home, we see that 1 in 5 Malaysians have a disorder of gut-brain interaction. We also know that this is more common in female, and while it may not be unrelated to an organic disease, we know that there is a significant impact on healthcare-related quality of life because when patients have symptoms such as early satiety, nausea, and vomiting, they are unable to finish a full meal, and this can cause a lot of problems with emotional distress, anxiety, as well as can lead to depression. And there is a bidirectional relationship with the coexisting anxiety and the anxiety that disorder of gut-brain interaction can cause and its relationship to symptoms. As such, it is very important for us to understand that the control of symptoms are of utmost importance in the patients that we encounter. So now I'm going to talk about what you may see in your practice. So you see a gentleman that comes into your practice and says that he's got epigastrium discomfort. Occasionally it's so bothersome and causes him pain. He's got retrosternal burning as well, and he's got a sensation of an acidic taste at the back of his mouth, or a water brash sensation. So you need to understand that the first and most important thing when you see a patient like that is to determine whether or not they have an organic disease, because you don't want to be missing an underlying esophageal or gastric carcinoma or peptic ulcer disease, or other underlying diseases of motility such as achalasia cardia or ineffective esophageal motility. So the first thing that we need to do is really to characterize their symptoms. Are they related to meals? And are there certain food triggers that can cause the generation of epigastric pain? Commonly, spicy food, because we know that capsaicin can bind to the receptors of pain and also generate symptoms. Caffeinated beverages, because they increase acid production, and also citrus food. Some patients can also report that late meals can trigger symptoms, and in patients who have red flag symptoms such as unintentional weight loss, the presence of either altered blood in their stool or hematemesis, which is defined as vomiting blood, this should prompt you that the patient needs an urgent upper gastrointestinal scope in order to rule out the presence of either malignancies such as gastric cancer or even the presence of peptic ulcer disease. So the next thing that you want to know is whether there is a personal family history of gastric cancer. We know that a first-degree relative of gastric cancer increases the patient's risk of gastric cancer. Therefore, in a patient who's got a first-degree relative, they need investigation. And once we have ruled out the presence of organic disease, and in a patient who is less than 55, then we can consider the possibility of functional dyspepsia in this patient. The guideline states that all patients above 55 need to have a full blood count, and if there's the presence of either anemia or thrombocytosis, meaning an elevated platelet, they should undergo an OGDS. And the reason being anemia is associated with gastric cancer as well as thrombocytosis, which is elevated platelets. So now we have a definition of functional dyspepsia, which is an absence of organic symptoms that explain the epigastric pain, burning, early satiety, as well as a sensation of fullness that results in an inability of the patient to completely finish an entire meal. Now, again, functional dyspepsia can overlap with GERD, or GERD can exist alone. And after these slides, we're going to also talk about what we call refractory GERD, which is GERD that is unresponsive to your usual dose of PPI. So now we're going to talk about the pathophysiology of functional dyspepsia and why understanding the underlying mechanism of symptom generation is so important in the treatment armamentarium of our patients. So one of the main causes of functional dyspepsia is delayed gastric emptying. We know that when food sits longer in the stomach is distended, and this is what causes the symptoms of dyspepsia or fullness or bloating. Another common cause is impaired fundic accommodation. So when we eat a meal, as you are right now, the food is going from our mouth into our esophagus and thereafter into our antrum and then our fundus. So when the food hits our fundus, the stomach distends nicely to the pressure receptors that are activated. But in patients who have functional dyspepsia, what happens is there is an absence of that distension of the fundus, and this leads to a high pressure zone, and this is what results the symptoms of bloating and fullness. And in some patients, because of the high pressure zone and an increase in transient lower esophageal sphincter relaxation, this can generate symptoms of reflux in combination with functional dyspepsia. Of course, in the recent years, we've seen that John Talk and Tally's group have proposed that duodenal hypersensitivity and duodenal hypereosinophilia, commonly to the constitution of FODMAP diet, can constitute bloating as well as dyspepsia in patients. And also, we know that patients can have functional heartburn in which they have generation of symptoms of reflux without an actual acidic content. So with that, we see that there are two subtypes of functional dyspepsia, the first being epigastric pain syndrome and the second being postprandial distress syndrome. Now they differ in terms of the mechanism by which the symptoms are manifested. And epigastric pain syndrome is characterized by meal-induced epigastric pain, and this is due to gastric hypersensitivity and, very importantly, delayed gastric emptying, as well as increased presence of eosinophils in the duodenum. Whereas in patients with postprandial distress syndrome, what we see is actually the fact that the fundus does not relax adequately when the food hits the stomach, and this is what results in an inability of the patient to finish an entire meal. So now we're going to remember this because we are going to address the underlying mechanism of symptom generation in epigastric pain syndrome as well as postprandial distress syndrome and see how our treatment armamentarium differs in terms of symptom generation. So what are the symptoms of functional dyspepsia? In patients with epigastric pain syndrome, they usually report worst after a meal, and they usually are accompanied by epigastric burning. Whereas in patients with postprandial distress syndrome, what we see is patients complaining of a lot of bloating and fullness and early satiety, resulting them being unable to finish a meal. In addition to that, other less common symptoms can include upper abdominal bloating, nausea, as well as vomiting, but it must be remembered that nausea and vomiting can usually point to an organic underlying cause. So if the patient has got nausea and vomiting approximately 30 to 60 minutes after a meal, we need to rule out the presence of gastric outlet obstruction. We should get a plain abdominal X-ray, and if there is evidence of gastric outlet obstruction, do an OGDS, and if we see a very tight, unrelaxing pylorus secondary to a possible tumor, then we need to put in a nasogastric or a nasojejunal tube in order to relieve the site of the obstruction so that the patients are able to tolerate orally. Other less common symptoms include heartburn as well as regurgitation that can signify an overlap of functional dyspepsia as well as GERD. So now I'm going to highlight the importance of treating Helicobacter pylori, because Helicobacter pylori is one of the main causes of dyspepsia. So in this study, which recruited an impressive 6,700 patients who were Helicobacter pylori, they were randomized into either no treatment or treatment for their Helicobacter pylori. And we see very remarkably that the treatment of Helicobacter pylori resulted in alleviation of symptoms of functional dyspepsia with a number to treat of 9. So now we're going to switch gears to talk about how we go on to diagnosing functional dyspepsia. So the further question that you need to ask any patient that presents to you with epigastric pain, early satiety, and bloating is when the first onset of symptoms were, because Rome 4 states that the symptom onset has to be at least 6 months prior to the diagnosis, and they have to have active symptoms for the past 3 months and experience at least one of the following that is bothersome: postprandial fullness or early satiety at least 3 days of the week, epigastric pain or epigastric burning at least 1 day of the week. And in addition to that, they have to have a normal OGDS, and as we discussed earlier, any red flag symptoms should prompt you to an underlying organic disease that needs immediate investigation. So now we're going to switch gears a little bit and talk about reflux right now. I'm bearing in mind that I only have 17 minutes left, so we're going to speed up a little bit. There are a few types of reflux that one can get. Now, the commonest is acidic reflux, but patients can still experience reflux in the absence of acidic reflux, and this can be due to bile reflux, this can be due to gas reflux as well, and some patients can get bothersome nocturnal symptoms, especially if their meal is less than 2 to 3 hours before their bedtime, and patients can also experience extra esophageal reflux manifestation, and this includes chest pain, hoarseness, frequent clearing of the throat. It can also include frequent exacerbation of asthma, and it can also include laryngopharyngeal reflux that causes chronic cough. So what is the pathophysiology of gastroesophageal reflux disease? Most importantly, it is impaired clearance of the esophagus of the food bolus, as well as acid content. Number 2, impaired mucosal activity, especially in the gastroesophageal junction, and this arises due to the acid burden that causes an increase in chemokines as well as cytokines and perpetuates inflammation in the gastroesophageal junction. It can be due to a very poorly functioning lower esophageal sphincter, in which the lower esophageal sphincter is lax and the acid and chyme constituents from the stomach reflux up. Another common thing to remember is that patients can also have an acid pocket. Acid pockets are very responsive to treatments such as Gaviscon. And finally, we know that delayed gastric emptying that we talked about earlier can also cause the generation of symptoms of reflux. So now, when we see a patient who presents to us stating that they've got an acidic sensation in the back of their throat and water brush and substernal pain, again, it is very important to rule out the underlying organic cause of disease. And in patients with dysphagia, this may signify a peptic stricture or an esophageal tumor or even an esophageal mass or a motility issue such as achalasia cardia or ineffective esophageal motility. And if the patient has any evidence of upper GI bleeding, and this can be manifested by symptomatic anemia, a pale conjunctiva, passing altered tarry black stools from their back passage, and also hematemesis, which is vomitus of blood, this would prompt you that the patient needs early diagnostic evaluation with a scope. Now, in the absence of the red flag symptoms, we can consider an empiric trial of proton pump inhibitors for 8 weeks for a treat-to-test strategy to see whether treatment with proton pump inhibitors relieves the symptoms. So, if the 8-week of PPI trial helps in elevating the patient's symptoms completely, then we know that the patient likely has gastroesophageal reflux disease. So the question is, what do we then do after that 8 weeks of a trial of proton pump inhibitor? And we don't like to keep patients on long-term proton pump inhibitors because we know that long-term proton pump inhibitors increase the risk of Clostridium difficile infection. And this has a direct correlation to the dose as well as duration of proton pump inhibitors that the patients are on. So the moment they have symptom relief after 8 weeks, what we do is we then step them down to the lowest dose tolerable of proton pump inhibitors for another 2 months. And thereafter, I usually tell them that you can be off your PPIs and take it per required need when you have symptoms. Now, the question arises is what happens when patients have incomplete relief of their reflux symptoms to proton pump inhibitors? Do we double the dose? The answer is no. In the setting of an incomplete relief, the American College of Gastroenterology states that patients should be advised to go for further testing of proton pump inhibitors for at least 2 weeks and undergo an upper GI scope. Now, what is the rationale of patients being off proton pump inhibitors for at least 2 weeks? We know that if patients are on proton pump inhibitors and we suspect that they may have eosinophilic esophagitis, proton pump inhibitors can confound the histology of the biopsy, and therefore it is most accurate to be off for at least 2 weeks in order to enable the eosinophils to come back into the esophagus, and what we're looking for is at least 15 eosinophils per high-powered field in our biopsy of the esophagus. Other than that, we also know that in patients with severe symptoms, they could be having underlying erosive esophagitis of grade C and grade D. And the administration of proton pump inhibitors during the scope can confound the severity of our esophageal findings, and therefore they should be off it for at least 2 weeks. So when we do an OGDS and we see that the patient has erosive esophagitis of grade B or C or D, or the presence of Barrett's esophagus of 3 centimeters and above, this confirms the presence of gastroesophageal reflux disease. And the reason why they were unresponsive to the initial trial of proton pump inhibitor is likely because there was not enough acid inhibition by the initial proton pump inhibitor that we gave. So we may consider either doubling a dose or considering a potassium acid channel blocker such as Vocinti, especially when patients have LA grade C and D erosive esophagitis. However, if they have a completely normal OGDS or a very mild esophagitis of grade A, we don't see any inflammation, we don't see any erosions, the next thing that comes to our mind is, are we dealing with a motility disorder? So in this setting, we need to perform a 24-hour pH monitoring and impedance study together with manometry to look for the presence of achalasia cardia as well as ineffective esophageal motility. And if this is entirely normal, then we need to consider other causations of the patient's symptoms. So now we're going to switch gears and talk about the overlap symptoms of functional dyspepsia and GERD. So how common is this? So it exists in the United States at about a frequency of 7.4%. And when we talk about the underlying pathophysiology, which we addressed earlier, we know that the underlying mechanism is largely due to impaired accommodation and relaxation of the fundus, which results in a very high pressure zone in the stomach once the food is ingested, and this thereby triggers severe transient lower esophageal sphincter relaxation and thereby triggers the symptom of reflux. So when we treat a patient, we need to address these two factors. Number one, we need to suppress the acid, but we know that acid suppression in the presence of transient lower esophageal sphincter relaxation is not adequate because we need to address the lax gastroesophageal junction in order to improve reflux in these patients. So how do we achieve that? So again, when we talk about all the cardinal symptoms of functional dyspepsia as well as gastroesophageal reflux disease, we understand right now that there are a few types that can generate symptoms. And this gives us an idea of our treatment armamentarium. Number one, if patients' symptoms are largely due to acid, then they would benefit from proton pump inhibitors. But in many patients, when we do an OGDS in a patient with functional dyspepsia, we see minimal enteral gastritis to almost a completely normal OGDS. In this case, the patient is unlikely going to benefit from proton pump inhibitors alone. While it may help to reduce symptoms, it's not going to address the whole symptom control because we know that the patient's symptom generation is likely due to impaired fundic relaxation, as well as possible visceral hypersensitivity if the symptoms are triggered by stressful episodes as well as anxiety. So how do we treat this? We see that a lot of patients experience extremely bothersome symptoms. Approximately 50% of patients with GERD and functional dyspepsia overlap report that the symptoms bother them and impact adversely their healthcare-related quality of life. And we also see that there is an increase in healthcare-related seeking behavior in patients with overlap symptoms. So now when we talk about refractory GERD, we're going to talk about GERD that is unresponsive to the initial proton pump inhibitor of once daily dosing. So what is the mechanism of refractory reflux? So they can be many. Number one, you could be dealing with a patient with functional heartburn. So I'm sure you hear this terminology a lot. What exactly is functional heartburn? Functional heartburn is a situation where a patient does not actually have an acidic reflux. They don't have a bile reflux. And if you look at the symptom correlation in a 24-hour pH manometry and also pH study with impedance present, you will see that their symptoms of reflux have no correlation to acid at all. And patients with functional heartburn are best treated with a low-dose tricyclic antidepressant because we know what we need to achieve in these patients with functional heartburn is actually neuromodulation, where we modulate the pain pathways. And this cannot be done by proton pump inhibitors or prokinetics alone. Therefore, an addition of a low dose of amitriptyline, 12.5 milligrams every night, to patients with functional heartburn can greatly elevate their symptoms of not just dyspepsia, but also reflux. The next thing that we see is the possibility of reflux hypersensitivity. So what is reflux hypersensitivity? It is when a patient has a non-acidic reflux of bile contents that precipitate reflux in the patient. So in reflux hypersensitivity, again, we know that the reflux is non-acidic. So the addition of a proton pump inhibitor is unlikely going to elevate their symptoms. In this scenario, it's very important for us to consider the addition of a prokinetic, and we also need to consider the possible fact that they may have a pocket of bile in their stomach, which can be neutralized by immediate Gaviscon. Other disorders that we mentioned are disorders of esophageal motility, such as achalasia cardia, as well as the presence of eosinophilic esophagitis. Other non-esophageal disorders, such as rumination, as well as heart disease, can also mimic gastroesophageal reflux disease. Therefore, it is very important to distinguish them. So now we're going to move on to the treatment. So in patients who have bothersome, long-standing dyspeptic syndrome, we need to classify them into either postprandial distress syndrome or epigastric pain syndrome, because this is going to determine the type of treatment that will elevate their symptoms. In patients with postprandial distress syndrome, again, we need to allow the fundus to relax. So an addition of prokinetic, and the most effective being etopride, 50 milligrams, 3 times a day, 30 minutes before meals, has been shown to be very efficacious in the elevation of symptoms of postprandial distress, enabling patients to finish an entire meal after the administration of etopride. How about patients with epigastric pain syndrome? We know that in this subset of patients, a proton pump inhibitor is very efficacious at abolishing their symptoms. So after an 8-week time of treatment, what we do is we reassess them for an improvement of their symptoms. If they do not improve on proton pump inhibitors, we may consider the addition of etopride in addition to the proton pump inhibitor. And then we reassess them again 8 weeks later. And if there is no improvement of symptoms and a completely normal OGDS, this is the time that we may consider that they may have hypersensitivity reflux. And an addition of tricyclic antidepressants would be very efficacious in elevating their symptoms. So commonly in patients who have a completely normal OGDS but report very dyspeptic symptoms, I do a biopsy of the duodenum. And what I see in most patients is that they have duodenal hypereosinophilia. And this is really a condition where food triggers, especially high FODMAP constituents, can result in symptoms of bloating as well as pain. And in these patients, a trial of low FODMAP diet is very efficacious in elevating their symptoms of dyspepsia. So now we're going to talk about the prokinetic agents that are available in the market and which one is the most efficacious in reducing patients' symptoms. We have 4 classes, the first being a cholinergic agonist, and what it does is stimulates the muscarinic M2 receptor in the smooth muscle of the cells of the stomach, thereby stimulating contraction of the smooth muscle of the stomach. An example of this is bethanicol. The second class is the acetylcholinesterase inhibitor. And what this class of drug does is it augments acetylcholinesterase by inhibiting the activity of acetylcholinesterase, because we know that an increased level of acetylcholine in the stomach increases the smooth muscle contraction, thereby promoting gastrointestinal motility and resulting in improvement in symptoms of patients with disorders of motility as well as reflux. Another class is dopamine agonist, and we see that what this medication does is it reduces the inhibitory action of dopamine via the D2 receptor antagonism and accelerates the rate of gastric emptying. The class of this medication would be domperidone and etopride as well as metoclopramide. And finally, we're going to talk about the serotonergic agonist, which facilitates the release of acetylcholine from the myenteric neuron from the 5-HT4 receptor, and this results in improved gastric motility. And the class of drugs that we talk about is cisapride, metoclopramide, as well as mosapride. Now, etopride is a drug that improves gastric tone most efficaciously with minimal side effects. And this is a result of its dual mode of action, which is acetylcholinesterase inhibition as well as D2 receptor antagonism that increase both gastric motility as well as improve the gastroesophageal junction tone. So we see that etopride is indicated in patients who have functional dyspepsia and no underlying peptic ulcer disease, and also efficacious in treating GI dysmotility issues, especially patients with ineffective esophageal motility and patients with gastroesophageal reflux disease. So in this ANIC 2 study, in which patients were evaluated for their symptom improve after the administration of etopride, we see that bloating improved, as early as day 3 after the administration of etopride, and this significantly continued up to day 15 and thereafter. Other symptoms that continued to improve were upper abdominal pain, early satiety, as well as gastroesophageal regurgitation, demonstrating that etopride provides a significant rapid relief at as early as day 3 in symptoms of bloating, upper abdominal pain, early satiety, as well as regurgitation. And in this meta-analysis, which is the highest grade of medical evidence, we see that patients who took metoclopramide compared to domperidone had a significantly improved postprandial fullness compared to the patients who were randomized to domperidone. So now we're going to talk about the clinical efficacy of etopride in the management of overlap diseases. We see that when we compare etopride compared to proton pump inhibitors, it addresses the underlying mechanism of reflux disease by improving the lower esophageal sphincter tone, improving the esophageal acid clearance, as well as improving gastric emptying, and this results in a reduced episodes of reflux, whereas proton pump inhibitors only address the high acid production alone. So this goes to show us that in patients who are refractory to proton pump inhibitors who do not have an underlying organic esophageal or gastric disorder, the addition of etopride to proton pump inhibitors is an efficacious treatment strategy in order to address symptoms of both functional dyspepsia as well as GERD. Another study that was done comparing the addition of etopride to pantoprazole saw that at the end of 4 weeks, patients who were randomized to both proton pump inhibitors as well as etopride had a symptoms of GERD compared to patients who were randomized to pantoprazole alone. So how do we assess for the improvement of patients' symptoms of GERD? We can use what we call the frequency scale for the symptom of GERD, which is a clinically validated algorithm to assess the patient's baseline symptoms, the patient's symptoms at 8 weeks post-treatment, and the patient's symptoms 8 weeks thereafter when you start to reduce the patient's proton pump inhibitors. So now when we talk about the clinical efficacy of patients who are refractory to initial proton pump inhibitors, we see that patients who have inadequate relief as well as nocturnal symptoms who are given etopride have a significant improvement in their symptoms after the addition of etopride to the proton pump inhibitor, highlighting the importance of dual therapy instead of single therapy alone in the management of patients with reflux disease. And when we see in this study, at 8 weeks, etopride, in addition to proton pump inhibitors, significantly improved symptoms of heartburn, regurgitation, burning in the esophagus, postprandial fullness, abnormal refluxate of the contents of the stomach into the esophagus, as well as nausea and swallowing disorders. And now when we look at the clinical safety of etopride, we know that metoclopramide as well as domperidone have significant side effects. Domperidone, being a D2 receptor agonist, has serious possible side effects of QTc prolongation, and this can result in torsades de pointes as well as arrhythmias in patients who are above the age of 60, or if domperidone is given at a dose of more than 30 milligrams a day. It also has a dose-response relationship to the increased duration of domperidone, resulting in a higher risk of QTc prolongation as well as cardiac arrhythmias. However, we do not see this side effect in etopride, and in metoclopramide, we also recognize that because it's a serotonin 5-HT receptor antagonist as well as a dopamine D2 receptor antagonist, there are possibilities of tardive dyskinesia as well as akathisia, which are extrapyramidal symptoms that the prescriber must be aware of in patients who are receiving metoclopramide. And again, This increases with the duration of the patient being prescribed, and it increases after the dose of 30 milligrams. So we see that in etopride, there are no reports of extrapyramidal symptoms. There is minimal interaction with the cytochrome P450 enzyme. There is no prolactin elevation, which we see with metoclopramide as well as domperidone, and we do not see QTc prolongation as well as arrhythmias in these class of medications as well. So as such, etopride is a safe and effective medication in the treatment of both functional dyspepsia, GERD, as well as a combination of functional dyspepsia and GERD. So in the interest of time, I will not go through the case discussion, but I invite any questions from the audience after my session. So thank you very much for your kind attention, and I would like to open the floor to any questions from the audience.
Okay, thank you very much, Dr. Deborah, for a nice, talk on the, Ganathon and the usage and practical usage in a treatment. So you really have spoken about the GERD and also how to differentiate the functional dyspepsia and all that, which should be very useful. Otherwise, they'll just lump everything together as like one heartburn and all that. But you really nicely classified everything. So we do have questions from the floor. So this is the time for you all to ask Dr. Deborah. Let's start with the first question. A patient on PPI and etopride for reflux disease, the addition of probiotics, does it offer any benefits? If so, what will be the suggested CFU for probiotics?
Thank you for that question. So I think that's a very common question that we get, whether the addition of probiotics in functional dyspepsia and GERD would actually be efficacious. So it doesn't actually cause any harm, but when we look at randomized control studies of the efficacy of prokinetics and functional dyspepsia, the evidence is very, very weak. And when we look at the randomized control studies of GERD as well as probiotics, the evidence is again very weak. And the reason being, the amount of dysbiosis in the duodenum in patients with functional dyspepsia is very poorly characterized. And this is why we feel that probiotics does not have a role. And if we look at the International Society recommendations as well, they do not recommend the addition of probiotics to patients with functional dyspepsia or GERD or even an overlap syndrome.
Yeah, that's what I was about to ask, whether in any guidelines it's like mentioned or not really, maybe there's not much data, right?
That's right.
This morning I also asked the cardiologist the same thing about the omega-3 fish oil and all that, no? So it's a very common thing because the all pharmacies actually, they sell these things, right? So it's good to know. Okay, the other one is more like a scenario. In a 75-year-old patient with sudden weight loss, about 10 kilograms in 6 months, no gastric, yet loss of appetite, constipation 3 times pass motion per week, and bloating and fullness, will it be related? Okay, the question is also there.
Okay.
So what he's asking is there any relation? Yeah.
Okay, so when we look at the epigastric region, we need to understand that when a patient complains of epigastric pain or dyspepsia, there are 2 organs there. The first is the stomach, and the second is the often neglected pancreas. So I have seen patients, and even the guidelines say that in patients with uninvestigated dyspepsia at 55 years and above, they should have imaging of their pancreas to rule out pancreatic cancer, because this is the commonest way that patients present unintentional weight loss and dyspepsia. So in this case, what I would do is I would get the patient, firstly, because he's also got constipation, I would first get him a good abdominal ultrasound and also a CA19-9. If the abdominal ultrasound is abnormal or the CA19-9 is elevated, I would move on to do a CT pancreatic protocol in order to really characterize and evaluate the pancreas. And if that's completely normal, the fact that he's got constipation may indicate that there may be an obstructing tumor, and this patient would also warrant a colonoscopy for further investigation. Yeah. I hope that answers your question.
Yeah, I'm very sure. So you have to entirely inspect the whole GI tract, right? Not just the stomach. Pancreas often neglected. Usually we'll look at gastro and also the intestines, right? Yeah, it's good. Okay, so in a patient with symptoms of dyspepsia, okay, it's coming out on the screen, without any other complaint, but CA11199 shows very high value. Would you recommend them to go for a scope?
Okay, so CA199 is actually quite specific to pancreas. So if they've got dyspepsia, they're more than 55 years of age, and they've got a raised CA199, I would proceed straight to a CT pancreatic protocol because you don't want to miss pancreatic cancer. So I've actually seen a number of patients who have been treated by their primary care physician as dyspepsia. They've not responded to a 2-month dose of proton pump inhibitors. Their dyspepsia actually gets worse, and they come in and they've got a pancreatic mass that is a tumor. So this is devastating to miss. So whenever you see dyspepsia, raise CA199 CT pancreatic protocol.
So scan is a faster thing
Yes,
to detect anything.
the most sensitive, really,
Sensitive.
yeah.
All right, good. There are two questions, I think they're related. So they're asking, what's your opinion on those patients on high-dose PPI for long term? For example, omeprazole 40 mg BD, or those patients dual antiplatelet therapy. Yeah.
So that's a very good question. So whenever I see a patient who's on a proton pump inhibitor in my practice, I always ask myself, what's the indication? And if the indication is they've got functional dyspepsia, I don't give a BD dosing. I really try to reduce it to the lowest tolerable dose. The indication for BD dosing would be erosive esophagitis or peptic ulcer disease. And in any other case, you wouldn't be giving a BD dosing because you know that when you suppress the acid, and the longer you suppress the acid, the patient is at risk of developing Clostridium difficile infection. So after that 8-week mark, I always try to de-escalate. And in relation to the addition of proton pump inhibitors to patients who are on dual antiplatelet, now the American Heart Association does state that if they are above the age of 60, you can consider the addition of a PPI, but at a single daily dosing at the lowest dose, really, because you want to prevent the occurrence of ulcers. So I hope that answers your question.
Yeah, sure. I also have another question from myself. I always wonder, recently only, I think people talk about metformin-related bacterial overgrowth. I think, our patients, a lot of patients are on long-term metformin. So, they develop, diarrhea very much later, not in the early stage. We do understand when you initiate metformin, you do have this, but very much later, 20 years and all that. But could it be due to bacterial overgrowth and some role of metformin?
Yeah, so certainly. So we know that poorly controlled diabetes itself predisposes patients to small bowel bacterial overgrowth. So when a patient has got chronic diarrhea and they've got poorly controlled diabetes, again, what you want to do is you want to send stool cultures, you want to rule out the presence of Clostridium difficile, you want to get a good quality colonoscopy, rule out the presence of inflammatory bowel disease as well as microscopic colitis. And if they have no organic cause found and they've got poorly controlled diabetes, I would actually consider an empiric trial of rifaximin to address the underlying SIBO. And a lot of times my patients improve after that empirical rifaximin.
Yeah, because I think they are on long-term, this thing, right? Which sometimes overlooked this because you're focusing on other things like cardio-renal and so on. Okay, maybe one or two questions in the interest of time. So, okay, they're asking, many patients are worried about taking PPI for a long time due to adverse effects. How long do you think it's suitable, or how long have you kept them on a PPI?
Okay, so that's, again, a very good question.
Yeah.
So as I mentioned, the only time when I keep the patient on a high-dose long-term PPI is for Barrett's. So it's very important to understand that Barrett's is a precancerous state, and we need to suppress the acid to as low as we can. So this is the only scenario where it would be acceptable to keep the patient on a long-term PPI. And also in patients with erosive esophagitis, I would put them on a BD dosing or consider PCAPs. And after that, I would evaluate for healing in 8 to 12 weeks. And once I have seen healing in patients with erosive esophagitis, I actually de-escalate therapy to the lowest tolerable dose that doesn't produce symptoms. I don't like to keep patients on PPI for more than a year because we know that also, even though the association has been weak, we see the association of pneumonia, hypomagnesemia, and also the possibility of B12 deficiency in these patients who are kept on long-term PPIs. So I always try to de-escalate wherever possible.
That's good. All right. Is there any maximum duration for the treatment of with etopride?
So what we do in clinical practice is we give them etopride 50 milligrams 3 times a day. 30 minutes before meals for 2 months, and then I reassess them again. And if their symptoms are very well controlled, then I tell the patients that we need to start giving you a per required need, so you only take it when you have symptoms. So this is for patients with functional dyspepsia, but again, for patients with diabetic gastroparesis, we know that they need something to improve their motility. So in this scenario, I would consider the addition of Ganeton long term, but perhaps not 3 times a day, twice a day.
Twice a day will do. Yeah, they have motility issues, right? Yeah. So I think we have time for 2 more questions. So the second last question is related to gastroparesis. What's the benefit of etopride over EES in terms of gastroparesis?
Okay, so EES again is a very wonderful drug and improves motility, but we have to bear in mind that EES also causes QTC prolongation, number 1. Number 2, EES has got tachyphylaxis. So the more you give EES, the more patients are unlikely to respond to it the longer you give them. So Ganeton does not have this phenomenon. It doesn't increase the QTC, and it's not tachyphylaxis related. So because of that, etopride would be a safer agent in the long term compared to EES. When would I consider the addition of EES? I only consider it in patients who are very ill, in the ICU, poorly controlled diabetes, and they've got motility issues like gastroparesis. I consider a short duration. I see and assess them perhaps after 5 days to a week, and once they have improved, I start to de-escalate, and I keep them on Ganeton 50 TDS for at least 2 months, and then I de-escalate from there based on their symptom control.
Yeah, so it's not for a long term. And I like from a lot of your interactions, you're actually telling about de-escalate. So, it's always, for a certain thing, then we need to review the treatment and also de-escalate. And, it's not like forever, right? You need to continue with the medication.
That's right. Yeah.
Let's just go to the last question. In which situation you will start a patient with vonoprazan?
Okay, so that's a very interesting question as well, because I think that in the era of PCABs, we see that the acid control has been very, very amazing. So has PCABs changed my clinical practice? So I'm going to say yes and no. Yes, for patients with erosive esophagitis, we know that patients with GERD, LA, C, and D, when you do a scope, you see these large ulcers, they would benefit from a PCAB. But in patients with a GERD LAA, no, they have no benefit, because you know that acid suppression is not the cornerstone of management for these patients. The second instance where I would reach for a PCAB over PPI would be in a patient who's got Helicobacter pylori. And this is very important because we know that we need to suppress the acid in order for the antibiotics to work maximally. And when we talk about PPI, the maximum acid suppression is achieved at day 4 to day 7, whereas the maximum acid suppression of PCAB is achieved at the first dose. This renders the antibiotic efficacious from the first dose itself. So this is the other scenario where I would reach for a PCAB over a PPI. But for the rest, functional dyspepsia, functional heartburn, no, I wouldn't reach for a PCAB over a PPI.
All right. Okay, thank you very much. Ladies and gentlemen, let us give a big round of applause to Dr. Deborah. Thank you.